Sarcoidosis is one of the uncommon ones. So I was originally asked to speak about the treatment, or more generally about cardiac sarcoid. Because I don't know a lot about skin and brain and pulmonary sarcoid, we're going to focus on this. But I'm going to share with you some of our unpublished data from Mayo about our sarcoid experience here and in Rochester, and focusing specifically on outcomes and response to different treatments. So we're going to take about 20 minutes here. It looks like people are getting settled again. I have no disclosures. We're going to do three things. We're going to talk about when people should think that they might have cardiac sarcoid, what tests are reasonable and recommended according to our current guidelines, and finally, what are the treatment options and what is the prognosis with different treatment options like prednisone or similar steroid-sparing agents. So let's do a bit of an overview. First off, most people who actually have sarcoid in the heart have no symptoms from it. About 75 or 80% of sarcoid, which is detected at the time of autopsy in autopsy studies, never had a clinical manifestation. But those people who do, about 5% of patients with systemic sarcoid in the lungs or the lymph nodes would have cardiac involvement clinically. And most of what we're going to talk about is that although we do have data on people who have no symptoms but are diagnosed only by imaging studies, and we do know that there is a rate of progression from being asymptomatic to having symptomatic sarcoid, it does progress over the course of about 5 years or so. 4 out of our 13 patients progressed. I'll share that with you in detail. The second thing is the histologic finding on pathology of a granuloma is not specific to sarcoid. There are infections, classically tuberculosis. There are other systemic granulomatous diseases which have a variety of names I won't go into, but which could mimic sarcoid. So it's important, even if you find this, to think that there are other causes. But the hallmarks that distinguish sarcoid in the heart from other forms of much more common cardiomyopathies are blockage of the conduction system. Normally the upper chambers beat and then the lower chambers beat, and they're connected by electrical connection, and that gets blocked in sarcoid more commonly than in other cardiomyopathies. Arrhythmias. These are fast and dangerous, life-threatening arrhythmias called ventricular tachycardia, much more common in cardiac sarcoid than in other forms of cardiomyopathy. And the other hallmark, which we'll repeat again in the next couple slides, is failure to respond to standard guideline medication. We have guidelines in Europe and in the United States for the management of heart failure. These are well described. They're based on multiple randomized large clinical trials. But when you use these standard therapies for people who have cardiac sarcoid, they don't always work. They work a little bit, and they work a little bit for a little while, but the disease keeps going because you're not treating it, right? You're treating the manifestations, but you're not getting to the root cause. We don't know how many people in the world are affected by sarcoid, but we do know how many people in the world died from cardiomyopathy. This is heart muscle disease, which is not associated with valvular heart disease or blocked arteries. Those worldwide and in America are the most common reasons for heart failure. And I'll just share with you that in 2015, there were 343,000 deaths worldwide from the Global Burden of Disease Study. We published this last year, this month last year actually, showing that in men in blue and women in pink there, you can see that there were about 200,000 deaths in men, about 160,000 in women. And this is for all kinds of cardiomyopathy. Now, remember, sarcoid is a tiny piece of this pie. But since we can't measure the sarcoid-specific morbidity and mortality on a global scale, we use this as a surrogate. It's to give you a sense and put this in perspective. I'm sure everybody in the room has met people who've had heart attacks and people who've had strokes. The global burden of cardiomyopathy and myocarditis is 1/10 that of heart attacks and 1/3 that of strokes in general. So this is a typical echocardiogram. It's an ultrasound of the heart, and I'll walk you through it with this pointer, if I can get it to work. Let's see if I push that. Yeah. This is a little black area up here is the right ventricle. This is the left ventricle, the main pumping chamber of the heart. Left atrium, and this is the aortic and mitral valve. This chamber right here is supposed to pump 2/3 of the blood with each beat. 65% squeezes out each time. You can tell this is a very sick ventricle. it doesn't pump 2/3, it probably pumps 10%. And you can't tell, and I can't tell, why it's sick. It could have been that there was a virus causing a viral myocarditis. It could have been a lot of alcohol causing toxic myocarditis. It could have been a genetic problem that you inherited from your parents, a genetic or familial cardiomyopathy, or it could have been sarcoid. And that's why in our guidelines we want to figure out, based on common clinical features and simple imaging tests, who should go on to much more advanced imaging or a heart biopsy. And so there's some blood tests. These are all common things you've had. Glucose for diabetes, thyroid functions, the TSH for your thyroid function. These are general recommendations for all forms of primary heart muscle disease, which would include sarcoid at this point. But the echo in sarcoid is a little bit different. Sometimes there are features that give you a clue. This is that same ventricle we saw before, but it's different, right? This part of the muscle is squeezing well, it's thickened, but this part of the muscle is not squeezing well, it's thin compared to this area. It is thin and it actually has an aneurysm. It's going the wrong way when the rest of the heart squeezes. And that's called a basal septal aneurysm. 13% of Mayo Clinic patients who have cardiac sarcoid have this feature, only 13%, but if you find it, it's very specific. It's one of the helpful things. Again, the reason I'm showing you this is to show you that sarcoid is this needle in the haystack, but by keeping aware and keeping a careful attention to these little features, you can get to the point where you can decide who needs the MRI or the PET scan or the heart biopsy. So we'll go to the next one, and we are going to get to treatment in just a second. Oh, this is going the other way. So the features, this is a table, you don't need to memorize it, from our 2016 management guideline for sarcoid. It's a copy right here, I'm going to put it in the back, so you don't have to read the tiny print. But the three things I mentioned, failure to respond to usual care, heart block, or ventricular tachycardia, high-grade heart block or sustained ventricular tachycardia. Those three things, when you get it with a cardiomyopathy, is a class 1, which means should be performed, level of evidence B, which means multiple studies, recommendation from the American Heart Association and the American College of Cardiology to perform a heart biopsy. Now, this assumes that there isn't sarcoid obviously in the lungs or the lymph nodes or some other skin, some obvious and safe place to do a biopsy. We do recommend that, of course, be performed first in the case of sarcoid. This is a sarcoid granuloma in the heart, and I'll show you this blue area here with the giant cells, is what they're called in the middle, is typical of a granuloma. What I want to show you is the normal stuff. Right here, the red tissue, and the red tissue over here, that's normal heart tissue. And it's immediately adjacent to the granulomas. And that's the challenge with sarcoid. It's a focal disease. It can affect one area, cause damage, and 2 millimeters away from that, it's going to be normal. And so there's sampling error, right? You can't just biopsy blindly. If you did, you would miss the granulomas 80% of the time. So the next few minutes, we're going to talk about ways to find granulomas. And the first is with MRI. This is not sarcoid, it's lymphocytic myocarditis, actually viral myocarditis, which is another inflammatory disease of the heart. This is an MRI. Blood is white, muscle is black, and there's a white rim at the end of these red arrows, which is abnormal. This is an area of inflammation caused by a virus in this patient. And this is a mouse that used to live in the Birdsall building across the street here. And this mouse had Coxsackie B virus myocarditis. It's a model that we've used for many years in our laboratory. And you can see this blue area on the epicardium is very similar to the white area on the MRI. This is the inside of the heart muscle epicardium. Why am I showing you this? Because sarcoid, like this model, is very focal. If we did a biopsy of this mouse on the inside of the heart, or we did a biopsy of that patient on the left, we would miss the inflammation because we biopsy the inside of the heart, and the inflammation is only on the outside. So this is another example of an MRI. It uses a much newer sequence, one that we use routinely here for sarcoidosis as well as myocarditis. You can see blue is blood, green is heart tissue, and red is inflammation. Well, we only biopsy down here in this right ventricular septum. If this patient who really we thought had sarcoid or myocarditis, we biopsied, we'd miss it completely. So again, imaging is key in localizing inflammation. Those 2 slides I showed you were MRIs. It's a kind of imaging test. Big white donut, you go, makes a lot of noise. There's another kind called a PET scan. It's also nuclear. It's nuclear imaging, and in PET imaging, which looks at both inflammation and perfusion, which is blood flow, there's a 4-fold increase in the risk of death or ventricular tachycardia if you have an abnormal study in the setting of suspected sarcoid. Very important test. We do this routinely. It's a hard test to do. It requires fasting and a high-fat diet before the fast. This is an example of a patient who is this image was sent to me by my colleague in Helsinki, where they do a lot of sarcoid research. And you can see all these dots here are granulomas. They're areas of inflammation on the PET scan. Following Remicade treatment, you can see it got better. And so this is the patient had cardiac sarcoid. This is as well as systemic sarcoid. I should tell you 50% of patients with cardiac involvement do not have any extracardiac disease, which is why it's sometimes very hard to identify. In our final 10 minutes, we're going to focus on treatment, which is really what we were interested in. And now you have the framework to say that we know that sarcoid's the needle in the haystack. If you find it, it will change your management. You will add prednisone or another immunosuppressant drug, usually in addition to guideline-directed management, which would include perhaps a pacemaker if it's heart block, or an implantable defibrillator if you had symptomatic and sustained ventricular tachycardia. So at Mayo Clinic, between 1994 and 2014, we had 574 patients who had both a diagnosis of sarcoid and a diagnosis of cardiomyopathy. You needed both. And unfortunately, many people did not have heart biopsies or were here just for one visit. And because this was a longitudinal study, we did not study those people in this particular paper. We did end up with 91 patients who had multiple visits and who had biopsy-proven sarcoid and who had imaging or biopsy in the heart consistent with sarcoid. About 51 was the average age of our patients, and about 1/4 were female. Most of these patients were from Rochester, Minnesota. You know, you betcha. Good, somebody got that. Anybody seen Fargo? They really talk like that. Most were from Rochester, the most Caucasian. We had 44 months of average follow-up. About half of the patients presented with heart failure. I'm a heart failure doctor. I'm not an arrhythmia doctor. And so there's a little bit of bias because I get referred a lot of cardiomyopathy. About 1/3 presented with heart block, which is where the heart doesn't beat properly and you need a pacemaker. And about 1/4 presented with sustained or symptomatic ventricular tachycardia. Now, importantly, 13 patients had imaging only, and I'll just mention that. These are people who might have had a biopsy of their lung, and then the doctor said, oh, wait, I think we should do an MRI or a PET scan of the heart, even though there were no symptoms in the heart. And of those 13 people, and I'll only mention this here, 4 went on to develop sarcoid in the subsequent 5 years in the heart clinically. 3 developed a cardiomyopathy, and 1 had a sudden death episode from sustained ventricular tachycardia. So there is a rate of progression. However, it is not nearly as progressive as people who have more advanced disease at baseline. This was a fairly sick group. The average amount of blood pumped by the heart with each beat was 37%. That's the ejection fraction. That's a pretty low number. 65 is average. What about treatment? You can see here 88% of people were treated with prednisone. And throughout the literature, that is still the backbone of therapy for cardiac sarcoid. And in addition, we tried mycophenolate and a number of other medicines, methotrexate, and a long list here of one-offs in order to decrease the steroid dose. I started using mycophenolate about 15 years ago, and the reason was to minimize steroid toxicity. It wasn't that I thought mycophenolate would do better. I thought that it would just prevent people from getting diabetes and bad bone disease. And so let's look at the outcomes. I'm going to show you, based upon therapy, I'm going to show you 3 graphs. And these will tell you what happened to patients based upon their initial treatment regimen. This is not a randomized study, it's observational, and so there are biases. And in the question and answer period, we can talk about the many biases in this study. but there were a few who did not receive immunosuppression, some who received prednisone only in the first 90 days, and another group that received steroid-sparing agents as the initial treatment strategy. And you can see the likelihood of an improvement in ejection fraction, and all of the patients got guideline-directed therapy, was equal in the three groups. And it wasn't bad. Overall, about 44% of people on average improved by more than 10 ejection fraction points in our core lab review of the echoes or MRIs. And so that's not bad. You know, some people do get better. But what about the people who get worse? This shows you the rate of heart failure events, and we define that as being hospitalized for heart failure or having a 10% or more drop in ejection fraction. And unfortunately, all the way up to 5 years, there was no difference between the groups statistically, and indeed, there was complete overlap and about an overall 50% rate, which is 10% per year per group. So unfortunately, if you present with cardiac sarcoid clinically, the likelihood of having another heart failure event in the next year is about 10%, and we don't have really no treatment arm, so we don't know what that would be. But I think we can say that after adjusting for different biases, that the likelihood of that event is pretty much the same or very similar, whether you have a steroid-sparing agent or not. However, the side effects of your drugs would be different. Because 61% of our patients were able to wean off of prednisone when they were on a steroid-sparing agent. What about arrhythmias? Ventricular tachycardia did not vary by group, and you can see the overall rate's about a little bit under 40% on average, and that is a pretty high number of subsequent arrhythmias. Most occurred in the first 2 years. We would say that the likelihood of death or transplant is higher if you presented with a cardiomyopathy than if you did not, but there were still people with ventricular arrhythmias who progressed to require a heart transplant within 5 years. In conclusion, there are high event rates in all treatment groups. Steroids remain the backbone of therapy. Often we will use a mycophenolate or methotrexate as a similar drug to minimize steroid toxicity, but we do so to improve the side effect profile, not so much because it's more efficacious. There are 2 trials ongoing. David Burney at Ottawa Heart Institute, he's an electrophysiologist, very active in this field, has actually a trial that's being randomized right now to methotrexate with steroids or steroids alone. That's, again, actively enrolling, but only in Canada. And the group in Helsinki is starting a trial specifically in cardiac sarcoid, looking at infliximab in people with relatively preserved ejection fractions. And then there are a number of registries that are ongoing. And with that, I'll stop and say thank you for your attention.